So we did diagnosis. This is going to be management, which is a lot. This is all, I'd say this is 80% of my practice, at least, management. So management of wet AMD, there's, observation is not mentioned in the textbook. So there's observation, laser, PDT, anti-VEGFs, and then there's special situations we'll talk about. So observation, I think, is perfectly appropriate in many cases. I have a couple. One is a new thing that they were talking about at Academy, and there have been a couple articles on, which is called quiescent or non-exudative CNV. So it's kind of dry wet AMD, which you can only see in certain ways. Asymptomatic AMD, wet AMD, there's nothing on. So I got to probably work on that paper. And then if there's low visual potential, either because the macula is burned out or the patient has something else wrong with them, I think observation can be considered. Entity called quiescent CNV. Actually, they call it treatment-naive quiescent CNV or non-exudative CNV. So there's a dry OCT, but they have a membrane, which you can only see on ICG or OCT angiogram. This was an 84-year-old woman I saw who came in because the left eye was exudative. I keep using these pictures. You'll see her picture in a minute. But this was the right eye. So the right eye was 20/25, no symptoms. This was the color picture, which looked pretty good, although there was an absence of drusen in the middle. This goes way back before the OCTs. But if you see a patient with wet AMD and there's drusen everywhere and there's not drusen somewhere, that makes you nervous because there's probably something else going on in that spot. And then this was the multicolor, which was kind of funky looking with that elevated area in the middle, which looks green. Excuse me. And then the autofluorescence was kind of nothing. The OCT was totally dry, but you see the lumpy PED there, and then the fluorescein shows early hyperfluorescence with late, I don't know if you can really say that that's leaking. I don't think it is, it's just sort of sitting there. And then the ICG has just got an obvious membrane. So if you see a big plaque like that on ICG, that's a neovascular membrane. So there's a big neovascular membrane there that's doing nothing. And then if you look at the patient, I didn't do anything to her, and if you look at her over 18 months, it does grow. So if you look on the IR, the one on the left is initially, the one on the right is 18 months, and that area is getting a little bigger on top. And so this is treatment-naive, quiescent, or non-exudative. There's two papers that came out in the last 3 months on this. One's out of Italy and one's out of Singapore, and they followed these people for about a year, and they do pretty well. The one had 6%. One of the patients, these are small studies, that's the thing. So in one study, one person activated, and in the other study, 4 people activated within the first year. So I definitely think these people can be watched. There's some, early in the old days of pathology, there were people who did histopath who showed that neovascular, Dr. Pave would remember all this, neovascular membranes were actually not that uncommon. And there's thought that they might be somewhat physiologic in some people, that maybe the body needs more blood supply. So that's non-exudative wet AMD, which you'll hear more about. Asymptomatic wet AMD is apparently just my thing. No one else does this. So you can ignore this as far as anybody but me. This was an 84-year-old female who came, this was her other eye. So this was she was referred for, this is one I showed you before. So she got exudates in the macula, she's got a bunch of fluid, she's got a membrane, and you can see the intraretinal hyperreflective material, a little bit of fluid under the fovea, but she's totally asymptomatic, she's 20/25. And that's the fluorescein, which shows like a little net by the nerve. This was interesting. I showed it to my partner. Oh, I don't have the ICG. I'm sorry about that. So what she has is she's got this big subfoveal inactive one, and then she's got a little juxtapapillary active one. And I watched the asymptomatic ones. That's just the way I was trained, but it was a long time ago. She got better. So in 18 months, the fluid went away completely. So she with nothing. So she was managed with observation. So anyway, I got to pull my charts and figure out, because there's the juxtapapillary ones we used to watch, but I have to say the treatment now is safer, so I'm not positive what the right thing to do is. So that's asymptomatic wet AMD. I put something in my chart saying the reason I think you can watch them medical legally is none of the studies included asymptomatic patients. So if you look at any of them, the Marina, the Harbor, the whole buffet of studies, I think there's 10 or 20 now. On wet AMD, none of them included asymptomatic. And on the other side of the equation, which is the people with poor vision, none of them included people with 2200 or worse, or 2400. So if you have someone with asymptomatic or someone with very poor vision, you can't necessarily generalize the studies to them. So the other people I observe, most asymptomatics, all of the treatment-naive quiescent ones, and then if someone's got no visual potential. So if there's geographic atrophy, this picture here was someone just came in 2 weeks ago, and there's geographic atrophy in the middle. She didn't notice that. There's a big hemorrhagic PED on the edge of the scar. I didn't treat her. And then if there's this person on the bottom has AMD, and she had a membrane, and I treated her for a while, and she dried out, and she stayed at that. And I think that is from her pucker. So what I did was I extended out her treatment, and sort of she had a little bit of fluid there, and it's been stable, and her vision's excellent. She's 25, I believe. So I think if there's something else that's keeping them. And then a discoform scar. So this is a discoform scar. So this is super common. You get somebody with a big scar and there's fluid, and are you going to treat that person? There's a certain point where you hit the floor with your vision. You're not going to go lower. So my algorithm is based mostly on the fellow eye for these. I do have people I'll treat every month like that who have a scar in the middle and the other eye's wiped out. So there's some people where that's the good eye, and there's still, the other thing you have to watch out is the vision. So I say, what's your vision? And then the other thing you talk to people is like, how are you, like, do you read? I have people who are 2200 who knit, play bridge, and go to bingo every week and watch TV and are perfectly fine. And then there's people at 2200 that, I have a guy with a seeing eye dog. So, so you have to find out their visual function, and if they're very functional, you want to maintain that. So that's kind of poor vision. So then thermal laser is possible but not common. I have to say, in the textbook, they do have the macular photocoagulation study, which I think is so old and historic. It's almost like leeches. But the macular photocoagulation study showed that in rare cases, laser is appropriate. This was an 85-year-old patient I saw just about 5 years, maybe 8 years ago, who had this juxtapapillary membrane. So there was but you can see there's subretinal fluid. You see the hemorrhage, just nasal lithophobia. So this person had an exudative detachment, 2100 vision in this superior, superactive juxtapapillary net, and I believe was pretty old and frail. And I said, why don't we just laser it? So here's the FA showing it's pretty small, and then here's the laser. And if you laser these, you got to laser them to white. And then the other thing to watch is the papillomacular bundle. This was a good one for laser because it was superior, wasn't in the papillomacular bundle, and the patient did fine. The vision came up. So the laser photocoagulation study showed. So
you're assuming there's a net there, or you had like.
No, the FA showed it. That's the FA.
I just call that leakage or something.
Yeah, but that's the whole thing. That's a late FA, so that would be the whole thing. If it was a cold, that would be the whole thing. I think I might have gotten an OCT up here too, just to get the edges. But there's nothing in the macula. There's nothing central. Okay. It's all just peripapillary. Yeah, you're supposed to go a little bit beyond the border. You got to go about 200 microns beyond the border, 500 for PDT, and you got to get it to white. And then, so the macular photocoagulation study showed an advantage to laser, but it was very few patients. So if you looked at the numbers, and I didn't look at them for this, it's just what I remember, there were essentially 12% of the patients with wet AMD present with extrafoveal lesions, which is not many. And the recurrence rate after treatment was 50%. So you had essentially 6% of people benefited. So that was back with the laser days. And the other thing is you can get a blind spot from the laser that people can notice. So it's rare that you'll ever consider laser, but it's not never. So that's laser photocoagulation for wet AMD. And then photodynamic laser for wet AMD is also something we do sometimes. It's rarely used. It's mostly for polypoidal. And then it's also, if you look at the study, so I'll show you in a minute, but have you ever seen a PDT? Do you do them here? You do, okay. So if you infuse verteporfin over 10 minutes, it washes out over 5, and it preferentially deposits in the abnormal vessels. You activate it with a low energy laser, which is about a laser pointer. And then the other thing is, just before the anti-VEGFs came on board, like within 6 months or a year, papers were coming out on intravitreal Kenalog with PDT where they were getting pretty good visions. But then since the anti-VEGF supplanted it, no one ever studied that. But if I was getting PDT and the lesion was anywhere near my central vision, I would put Kenalog in at the same time or the day after. Don't put it in before. You won't be able to do your laser. And they have to stay out of the sun. And when you infuse verteporfin, someone has to sit there and watch the infusion, because if it extravasates, you can get necrosis of the skin. So you guys probably have to do it, but I have a staff member, so a staff member sits there and stares at it. And I almost fired one. When we used to do these all the time, I had somebody work with me for years who was very nice, and it extravasated, and I almost fired her on the spot because she just was wandering around doing stuff, and called me in the room, and there was a big extravasation. The patient did well, but what would happen is it would burn. I had one woman call me almost every hour through the night saying how much it hurt. So, you can lose your skin there. So just put it in a good vein and watch it. And then I couldn't find the early PDT studies, but the control arm for the anchor study was PDT. And this is what they do. The vision gets worse on average. So if you look at but it got less worse than it did without PDT. So PDT, but nowadays PDT is really for extrafoveal lesions, or lesions where you're not sure if it's central serous or not, which is what we looked at today, which is this. So I had this 77-year-old man, which is, he was also Caucasian. It's pretty old for central serous, but he was on steroids for COPD, and he had a drop in vision in the right eye. And when you looked at the ICG, it was kind of this patchy filling, nothing so striking. The fluorescein didn't show much. The OCT, though, showed subretinal fluid. And so I thought, well, this is kind of weird, but maybe it's central serous. We haven't stopped his steroids. His vision wasn't that bad. I watched him pretty closely, and the fluid just stayed there for 6 months. So then I thought, maybe it's one of these mixed. So I PDT'd the area superior. You see that little white spot superior to the fovea? So I try to stay away from the fovea. So I just PDT'd that, and it went away. So this is kind of like, I get patients who are central serous, or I have some people that are central serous that convert to wet AMD with hemorrhage. The OCT angiography will be great for this, because the OCTA patients, OCTA studies are showing that, I think it's 10%. There's a fair percentage of central serous where there is a membrane, especially in the older patients. Oh yeah, and I was going to say on those, the other thing with those quiescent CNVs was that the OCTA studies show that they grow. There's something else, but the OCTA will be helpful for these. So you can use PDT, and so there's, and then the main thing now is anti-VEGF. So observation laser and photodynamic laser are rare ways to manage wet AMD, but they're possible. And then the main thing we do is anti-angiogenics, and that involves Macugen, which doesn't exist anymore, pegaptinib, which is nice because I can never say it. And then bevacizumab, ranibizumab, and aflibercept. You were talking about memory things. I have trouble with remembering these things. I just remember Avastin is early in the alphabet than Lucentis, and bevacizumab is earlier in the alphabet than ranibizumab. I don't know if that helps you. And then you may or may not need to know what these are. So I forget about Macugen. Bevacizumab is an antibody. So it's a full antibody to VEGF. It was developed for cancer. It's a humanized monoclonal antibody, so it's got the whole thing. Ranibizumab is just the fragment, so it's just the FAC. It doesn't have the tail fragment to VEGF, and so it's smaller, and it's also optimized. In a test tube, the binding affinity of ranibizumab is 40 times the binding affinity of bevacizumab. So they're in a test tube stronger. Aflibercept is a fusion protein, which is, it has one arm has the antibody to VEGF, one arm has the placental derived growth factor, and then it does have a tail that was put on it. So it looks like a full antibody, but it's synthesized, so it's not considered a monoclonal antibody because it's not made that way. That's why it's called a trap. But they all just attack VEGF. So they all attack VEGF. The reason there's some importance in the difference is your body tends to protect antibodies. So if there's an antibody in your circulation, your body doesn't eliminate it because you want to keep it, because you want to fight disease. So there's a way for your body to, so antibodies that get into your bloodstream tend to stay there for a couple days or a week. Whereas theoretically, the fragment, the Lucentis fragment, if that gets in your bloodstream, your body just eliminates it and gets rid of it. So when we were treating that pregnant woman, which everybody else in the world said they wouldn't do, we were using Lucentis. And I've talked to some specialists who say there's evidence that that's safe, and she did okay. Anyway, and then this is the Marina study, which validated Lucentis. This was in 2006, I think it was published, and they had the two doses, 0.3 and 0.5, which were pretty close. We ended up with the 0.5, and then sham, and this was a sham arm because it was during PDT, but there were certain lesions PDT didn't help with, so they allowed a sham, and it showed this huge benefit. So if you look at it's 21 letters, which I think is 4 lines on the chart. I think 15 letters is 3. It's a lot of lines. So this is a huge change. Everybody used to go blind from macular degeneration. Now they don't. It's such old history, but it's important because people will start complaining about the shots. And I mean, 20 years ago, there's people who would travel anywhere to get these shots. So I'll tell them, I know it's a pain getting shots in your eye, and it's miserable coming in every month, but without it, you tend to lose vision. On average, people lose their central vision and become non-functional. That's the other thing. You get the 97-year-old people who say, I'm too old, I don't want it. And you say, well, you want to maintain your independence. So if you want to maintain your independence, you need the shots. This is the Marina study. One way to tell the newer studies from the older studies, all the new ones have a name that's like real. The older studies just had abbreviations, but the new ones are all names. So Marina was the original AMD study. Since then, there's a bunch of studies. So after the Marina study,
I didn't follow that.
What's that? The different names?
Yeah.
Oh, because we were talking about the old CRVO study.
Yeah.
Since the last decade, all the studies have some sort of a word, like laptop or balloon.
Like
they pick a word.
Okay.
And they
Marina's a word.
Yeah, Marina's a word.
Okay.
Harbor's a word.
These
Bravos.
Those are old.
Those are new. No, those are all new.
Marina's old though.
Oh no, it's not that old. You're so young.
Oh, okay.
No, if you're going back, like macular photocoagulation study, MPS study, the DRS, the diabetic retinopathy study, the diabetic vitrectomy, they were just DRS, DVS, MPS.
I got you.
You can't use them in a sentence. So because you were talking about the older and the newer studies. So anyway, so after the Marina study, you couldn't do a placebo-controlled study. It would be unethical. So everything since then compares to Lucentis. And so that's what the View 1 and View 2 were for aflibercept. And then there's a buffet of ones that have compared Avastin, and they've all pretty much showed equivalency. So if you look at all the studies,
wasn't there one with the Avastin where it was better if they had worse vision? Like 2015?
Avastin was better than Lucentis?
I'm sorry, Eylea.
Eylea was better. There was protocol something in the DRCR net for diabetes. Yeah. But statistically, if you do 20 or 30 studies, and one shows a benefit, I don't know. It's a little hard.
So you don't do that.
No, I think Eylea is stronger. And I'll show you that. These are all the studies. I'm going to show you the PAT survey from ASRS, which shows what everybody does. And I do believe, so what I think I said, Lucentis is 40 times stronger than Eylea in a test tube. Lucentis is 40 times stronger than Avastin in a test tube. Eylea is 140 times stronger than Avastin in a test tube. So Eylea's got a way higher binding affinity than Avastin. So if you take 1,000 patients with the disease and treat them with everything, they do similarly. But if you take your hard patients out, if you do 500 patients, pick the 50 that are difficult, they probably do respond different to the other anti-VEGFs. And that's what everybody seems to find. And there have been some studies, there's some crossover studies with subretinal fluid that show that.
And then how do you choose between Avastin and Lucentis?
And Eylea?
No, just say it's an easy patient. You use Lucentis or Avastin. Is one cheaper and you go with that one, or?
I generally try to go with the cheaper one.
Which is
which is Avastin. I have to say, for a while I was spooked, and I have that in here. I have what people hold on right here. So this is your first line therapy. So in addition to me, you can look at the 1,027 respondents, both in the U.S. and internationally. It's interesting. In the U.S., most people use Avastin. Internationally, you would think people would use Avastin because we're the richest country in the world. But it turns out internationally, there's more of the brand name ones used.
They get it cheaper.
They do, I think. Yeah, I don't know what the number, but I think that's true. And then Lucentis and then Eylea are down there. So nobody uses Macugen.
Is there something about Avastin not being FDA approved?
Oh yeah, Avastin's not FDA approved. Yeah, and what I was going to say was Avastin spooked me because in 2000 and something, 2007, 8, or 9, there was a paper out of Bascom Palmer where there was a rash of blind eyes from endophthalmitis from a bad batch of Avastin. Mm-hmm. So I initially used Avastin a lot because Lucentis was aggravating me. Then I completely stopped using Avastin for 4 or 5 years. And then the batches were better. And then we had a problem with silicone in the Avastin. There was like a class action suit. So Avastin's not FDA approved. And the other thing is Avastin gets into your circulation more. And Lucentis is FDA approved, but Lucentis is crazy expensive. I mean, I was aggravated when they made the prices where they did. Eylea, I think, is a little bit stronger than Lucentis, but if you look at the long-term stuff, they're probably almost exactly the same as far as efficacy. There was a problem also with inflammation with Eylea that I did not have until recently. I think Aaron saw one of my patients. I think we do have a couple of people now with a little bit of inflammation from Eylea. Because these are all proteins. It doesn't make sense, actually, that your body is so forgiving to repeat injections of proteins. I mean, this is almost like what the allergists do when they're desensitized. You just keep injecting a protein. So we're injecting a protein in the eye and asking the immune system to just ignore it. And somehow it does, but sometimes it doesn't. So
What would you put in your eye?
oh, that's the next one.
Okay.
Hold on. Where's the one? It's in here somewhere. Oh, it's not in here. All right. I would probably start with Lucentis. And I have to say, I do start, I think in our practice I start pretty even. I would probably start with Lucentis in me. The Avastin's probably just fine though. And then Eylea, I like Eylea. They're all super similar. There's very little difference. It's hard to choose. And then the thing is how many, if you want to switch, so you have somebody who's not responding. So you're treating them monthly and they don't necessarily respond, or they're a sub-responder. When do you switch? Because some people take a while for fluid to go away. And this is most people wait till 3 to 6 injections, because there are some where it just takes a while to dry up. And that may be something, there's a thing on the table somewhere, tell me if this goes off with you, where they're mandating, there may be a step therapy mandated in certain insurance plans where you have to start with Avastin, and then you can switch if there's a non-response. The prices are astronomical.
Steve, they've done some studies on low molecular weight eye drops, anti-VEGF.
They weren't, so far those were not successful. All those were stopped, but there is something somewhere someone's doing, I believe, with an eye drop that they're trying to push into the eye electrically. So you put something topical on and then you do something and sort of like shove it into the eye, I think. That's on there. There's a lot of research being done on this, trying to get people away from the shots. I have to say the phase 3 for the, I should know all these names, for the Genetech, the intraocular device, does look pretty promising, where you might be able to put a device in someone's eye, fill it once a year. And then actually there's a phase 1 coming out, which we might involve with a genetic, because that's the other fancy thing, is you put a genetic vector in the eye and people make their own anti-VEGF, which is pretty cool. I have to say though, the thing is people don't even want to eat genetically modified food. So I don't know if people are going to want to be genetically modified themselves, you know. So anyway, it's a weird thing. So and then persistent. How do you manage persistency and AMD activity after 8 months? In Vision 2050, they've switched. I don't do PDT anymore. I did when the anti-VEGFs first came out. We were converting to PDT. I would not recommend PDTing these eyes if they're wet. Honestly, there's some evidence recently, and I don't know all these studies, but I can tell you from my patients, the people that are 20, 30 with a little bit of fluid over 5 or 10 years often will do a little better. They tend not to go to geographic atrophy. There's about 20 or 30% of these eyes, as you're treating them, they go to geographic atrophy and you lose it from that. So that I think a little bit of fluid is not necessarily horrible. So I don't necessarily go crazy about that if the vision's good. And then, and then how often you treat monthly? There's not many people, fewer than 10%. That's another thing. If you're lecturing about injections, when you're giving injections and you don't do as many injections, let's say someone does 10 and the next year they get 5, that's fewer injections. It's not less injections, because less is something you can't count. It's fewer, grammatically. You know, that's like cups of coffee versus coffee. It drives me crazy. None of the lecturers, they always say we gave less injections. And it's just like, anyway. Now it'll drive you crazy. You can join my club. So it's fewer, if you can count it. Like the checkout line now says 12 items or fewer in most supermarkets. It used to say 12 items or less.
That doesn't seem incorrect.
Which was wrong. Yeah, but no, fewer is something you can count.
It's very wrong, Mark.
Kind of horrible.
Yeah, if you want to go into ophthalmology.
It's you or your wife.
No, it's not me. No, like grammatically. It's a trait of certain people, I think. And then and then if you look at efficacy, everybody thinks Eylea is more effective. So it's an interesting thing. Eylea really is stronger. I have people that won't dry out on other stuff; they dry out on Eylea. But I think it's like weightlifting or carrying your groceries home. Like that time you have a really heavy bag, it's nice to be in shape, but most of the time you don't have that much. So I don't know if that's a good analogy. But most of the time you don't need the power. And then, and then how often do you get OCTs? How often do you get OCTs in testing on people? There's lots of ways to do it. I'm not an always. I've gotten to OCTs every 3 visits on them, if they're stable. So once they're stable and plateaued, we can do a treatment visit is super quick. So that's all what everybody does, and sort of an idea about treatment. And then treatment effect modifiers are interestingly in the textbook, and they list vitreoretinal interface. So a PVD is good. It may require fewer injections. And a macular pucker is bad. They might require more injections. And then there's complications, subconjunctival hemorrhage, like who cares? But you got to explain to people their eye can get red. It's a needle, and they're not zombies, so they have blood in their eye. And then inflammation, endophthalmitis is very rare. Persistent ocular hypertension is not that uncommon, 5 or 10%. Retinal detachment is super rare, but we did have one. A vitreous hemorrhage, and then systemic events are probably rare. And then, am I still recording?
Yeah.
Okay, thanks. And then, how often have you seen endophthalmitis? I think the number really is about 1 in 5,000. It's probably, some people get 1 in 10, but it's hard. It's a rare event, so it's hard to really nail it down. But it's pretty uncommon.
Is that gotten better over the years? 'Cause I was looking at the Rise and Ride
Yeah.
for DME, and they injected maybe 300 people, and there was about 4 cases of endophthalmitis.
Oh, in the DME, it might have been the diabetics get it. If you look at all endophthalmitis studies, diabetics get it more.
Okay.
There's
But
something
how about your practice?
I think we're about 1 in 5,000, roughly, for everybody. It's pretty low, but it's not 0. And then unmet needs, something that lasts longer. So this is, surgery. Oh, there's one more thing. Okay, surgery. So mostly for some macular hemorrhages, you can consider surgery. You can either do TPA, you can do intraretinal or subretinal TPA, pneumatic displacement, you can do translocation, but nobody really does that anymore. And removing the subretinal membrane, nobody does, and RP transplant, something you can consider if it's ever available. This was a submacular hemorrhage question, and there are people that recommended displacement. And then some people do a vitrectomy. Actually, a fair number, 25% do vitrectomies for TB. And what that is that's what I did on this patient. This was a lady who showed with subretinal hemorrhage. This was her better eye. She was reading until 2 days before she came in and she bled. So she had dropped to 2160. I thought, that's an eye with probable potential. Although I have to say the hemorrhage wasn't because it's not really nerfobia. So I wasn't, it was one of those, but she said she was reading, and this was her only eye. The other eye had a scar. So I pneumatically displaced it vitrectomy. So what you do is you make a little bleb of fluid with TPA, you put a bubble in their eye, sit them up, and the blood drops. And this was her shortly after the surgery, so the blood dropped inferiorly. Her vision only came up to 2100, so it wasn't like anything major.
Where is the injection? Subretinal?
Subretinal, yeah. There's a small needle. There's a 41 gauge needle is the Dewan one, I think, and then the Toth is a 39 gauge needle. And what you do is you make a subretinal bleb, and you do it. I use the silicone oil infusion machine, and outside of the eye, because it's hard to push through that small needle, and you have a TPA mixture that's the right concentration. And what you do is you get it so outside the eye, you get it so it's drip, drip, drip. And then you go in, and what I do is I have it on, so when I hit the retina, it blebs right up. So it's not like I'm trying to get under the retina. So I hit the retina, it blebs up. And you need a small needle, because if you have a bigger needle, your hole will open up. So if you go under with like a 23 or a 25, you infuse a little bit, and the retina rolls out, and you can't infuse anymore. So you need a needle, a small needle.
And it self-seals?
Yeah, and self-seals. You don't need to do anything with it. So that's kind of cool. And you can get those. But I don't know. I have to say I don't do it so much anymore. There's some recent studies. There was a study out of Korea where there was 2 studies. They weren't comparative, but they were published about 4 or 5 years ago. One was out of Wills where they operated their submacular hemorrhages. The other one was out of Korea where they never didn't operate. They did just injections, or vice versa. And if you looked at them, injections seemed to do fine. So there doesn't seem to be a big difference. So quickly, which anti-VEGF drug is a fragment? Do you remember? Yeah, ranibizumab. That's the fragment. Aflibercept is a
It's
synthesis.
not monoclonal antibodies, right?
And then which one's least expensive? We didn't talk about that, but they've asked them. They've asked them. And then Charles-Bonnet syndromes, when people see stuff that's not there, you just have to reassure them that that's not uncommon. 25% of people with poor central vision will see things that aren't there. I always tell people the common one I get is they'll look at the door and say it looks like it's made out of brick. So people, and you say, so the implantable telescope was FDA approved, but I don't think you guys aren't doing
Were you
it.
talking about that pamphlet?
Yeah.
Oh, wait, never mind, I'm confused. He was doing this?
No, he's doing the implantable telescope for a little
I
while.
was thinking of the telescope.
And I don't think you're doing it. Nobody's doing it anymore. It's just a really hard surgery. And then low vision, don't forget low vision rehabilitation for all your patients. There's a lot of things available now. So that's wet AMD variants. Or no, that's wet AMD management. So any questions about management? It's like what we do all
When
day.
you're giving these anti-VEGF things, is there any concern that like you're going below like the physiologic level of VEGF and that somehow you'll cause a problem by not having enough
Oh.
VEGF?
Yes, I think there is.
Okay.
So and it's weird. It's interesting. I feel bad for the macugen people. The macugen people validated intraocular injections, and they were careful to do just specific. They only inhibited one part of VEGF because they were worried about pan-VEGF inhibition,
Right.
and their product wasn't that effective. Genentech came in and just totally wiped out VEGF, and they managed to get over the finish line and make billions of dollars a year. The numbers are staggering, the cost of these drugs. I mean, at one point, when it was 10% of the Medicare budget was on
There was
Lucentis.
things, Trump is doing this with Part
Yeah.
B drugs. They say if we go to Japan's or level, it goes from $1 billion to like 200 million.
Right, yeah.
There's a
it's-
huge difference between us and Europe. And
How much we pay?
Yes.
It's interesting.
They're gonna change that over 5 years.
Yeah, it's not a bad idea. So, but I'll show you, I had this case, we run out of time in conference. There is this question about geographic atrophy and shots, and I'll wait till Dr. Aisham is back, because I think it's real. But you don't know, because you have to realize there never was a treatment for wet AMD, so you don't know the natural history of the RPE in patients with wet AMD who are being treated for wet. There's no way to do a controlled study of that. But I think there probably is a geographic atrophy. So what I do is if someone starts to develop geographic atrophy, I try to get people on the longest interval that controls their wet AMD. I really start pushing them out to 2 months or 3 months or 4 months, which you seem to be able to do. So that's the one thing. And then systemically, if you give these drugs for cancer in high doses, you do get events. You get strokes and stuff like that.